Okay, to continue our discussions, my dear students, we go now to the treatment of hypokalemia. Treatment of hypokalemia, so the drugs are used, or the medications includes, we have IV insulin, glucose, IV calcium, IV sodium bicarbonate, and inhaled albuterol. So all of these drugs uh, facilitate the shifting of potassium out of the blood and goes to the tissues. Okay, bicarbonate, I mean, may induce transcellular potassium shift. So we have here this hydrogen potassium exchange. So when sodium enters the muscles, it exchanges with hydrogen ion, and 3 sodium also exchanges with potassium via sodium potassium pump, that is active transport. Okay, for bicarbonate, when sodium enters, when sodium bicarbonate enters the body, it splits into sodium plus bicarbonate. The bicarbonate enters via sodium bicarbonate channel, and sodium ion exchange with 2 potassium ion. So that is 3 sodium exchange with 2 potassium ion. That is considered to be active transport. So based on these two mechanism, as you can see, there is what we call a movement of a potassium ion from outside to inside the cells. Okay, so hyperkalemia, excess potassium in relation to body water. So potassium ion is less than the 5 MEq or per liter that is standard. So we go now to the etiology and pathogenesis, or the origin of the disease. Okay, so there is an increase in potassium intake. So because of what? A rapid intravenous infusion of KCl, or potassium salt, or penicillin, that is being given by the physician. Okay, or increased potassium plus shift from ICF to ECF, from intracellular fluid to extracellular fluid, and deficiency of insulin, so diabetes mellitus, beta-adrenergic antagonist, acidosis, cell injury, familiar hyperkalemic periodic paralysis, wherein there is a problem in the muscle, like the muscle paralysis, which due to the high amount of potassium ion. So, or decrease potassium excretion, wherein there is a problem already in the glomerular filtration rate process, or decrease, that is considered to be oligoric, wherein there is less than 400 ml of urine are being excreted out of the body. So that is oligoric already. So oligoric is associated with renal failure. Kung ang patient may mga renal failure o difficulty in urinating na siya. So we have renal tubular secretion of potassium decrease, meaning if you have the renal tubules of your kidney or the nephron, so there is less secretion. When say secretion, the tubules will secrete potassium for excretion process, okay, together with the urine. Okay, so we have also the Addison's disease, or the adrenal cortical insufficiency, wherein there's a problem already in the hormone cortisol, or amount of cortisol or aldosterone in the body, which regulates also the sodium potassium ions, or the electrolytes inside the body, and even acidosis. So usually what will happen, if the potassium is 140 to 160 millimoles, so more of the potassium ion will goes outside of the cells. So try to see hydrogen and potassium exchange. We have sodium and potassium exchange via ATPase. Or in the principal cells, this is basolateral membrane, or luminal, okay, in the lumen. So we have tubular lumen. So we have again potassium ion, okay, exchange with sodium ion, and more potassium ion, it goes to the bloodstream, kasi bloodstream yan dito, class. Okay, so this one will lead to hyperkalemia already. Okay, principal cells are cells that are found in the lumen, or in the renal tubules of the nephron. So take note, nephron is the basic structural unit of kidney. Okay, so causes of hyperkalemia, so take note, we have renal failure, congestive heart failure, the RAAS blockade. Okay, if there's a blockade in the RAAS, then there is what we call more potassium ion will enter, and there is a sodium retention inside. Okay, decrease mineralocorticoid activity. Okay, so mineralocorticoid activity, it is a hormone that facilitates also the regulations of the potassium ion. Addison's disease, okay, the 4-renal tubular acidosis, okay, hereditary enzyme deficiencies, drugs via potassium sparing diuretics, ACE, okay, ACE inhibitors, beta blockers, adrenergic receptor blockers, spironolactone, so mostly mga diuretics. To shift potassium into the extracellular, okay, ito sa renal ha, extracellular. So we have insulin, okay, uncontrolled diabetes again, and we have the acidosis, tumor lysis syndrome, okay, and drugs and beta blockers and digoxin. So these are considered to be the causes of hyperkalemia. Usually the treatment of hyperkalemia is to, if there is higher level, of potassium, so pwede na yung dialysis, okay, the most common one. And of course, in the treatment, we are avoiding high amount of potassium intake also.